I love the fact that you guys are leading, which perhaps makes our students more ready to be able to enter the next generation workplace.
I think by upskilling a whole generation of physicians to think in that way can allow them to effectively implement these tools as they get deployed at their own health systems rather than relying on, a couple of subject matter experts that don't have the bandwidth to do so.
I want to play off something Shivam said too, because I think it's really important that we don't repeat, I think, one of the mistakes that happened when we started to implement EHRs. EHRs were developed by people who were data analysts, right? They were not developed for patient care. And physicians came late to that party. And as a result, we are still in like the Windows 2.0 version of EHRs.
So how do you get the enthusiasm that we feel in this room about and the value we see at the end of the journey of medical school? How do we get that to trickle into medical school, possibly by direct demonstration by faculty, but how do we get the faculty enthused and seeing the other side?
I just agree with you so much, Renu. Shivam's like smiling and nodding his head because it sounds like the vast majority of your work too, right? Is that faculty development, because that's kind of leading our next generation into the places that they need to be in terms of competency as well as understanding of using these technologies.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Gregg Malkary. I'm the Managing Director at Lighthouse Health Tech Advisors. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. Today, we're talking about how AI is shaping how physicians make decisions during training. We'll also be exploring why leadership needs to respond now to protect patient care. To be AI ready, doctors must learn how to think for themselves while they're simultaneously learning how to use emerging AI tools. The central question, though, is, are we training doctors for the world they're entering or for a version of medicine that's already gone? So over the next 30 minutes, we're going to examine how clinical pressure influences AI use in real care settings. And we'll also discuss what leaders must define clearly so safe habits form early in a doctor's career. This conversation is not about banning tools or slowing down innovation. It's about how students and residents can verify decisions when uncertainty is high. Peer-reviewed research shows that trainees accept incorrect AI-generated answers up to 25% of the time. So when a doctor is still learning or rushed to verify results, is it the software, not the physician, actually making the clinical decision? The answer often shows up on the screen before the trainee even has a chance to think. So when that risk reaches the bedside, it becomes a leadership issue with serious patient safety consequences. So today, to help me unpack this, I'm joined by 4 leaders who see these dynamics play out every day in medical education and clinical training. We have Dr. Saroj Misra, Associate Dean of Clinical Affairs at ATSU KCON. He manages rotations across dozens of hospital sites where he sees firsthand how AI affects both learners and faculty. We have Dr. Shivam Vedak, Clinical Assistant Professor of Medicine and the Associate Director of AI of Medical Education at Stanford University in Palo Alto, California. We have Dr. Mei Lin, the Assistant Dean of Graduate Medical Education at Toro University in California. She serves on national committees setting standards for AI skills in medical training. And we have Dr. Renu Agnihotri, the Interim Chair of Biochemistry at Still University in Kirksville, Missouri. She works with students at the start of their career just as their clinical judgment is beginning to form. So with that, let's start and look at where faculty and trainees are currently misaligned. Saroj, let's start the first question with you. How are you aligning expectations among attendees so that trainees receive consistent and practical guidance on AI use in real clinical settings?
Yeah, it's a very interesting sort of challenge because you have really two sets of inputs. You have the inputs regarding AI utilization that you are hopefully providing to students. And then you also have the inputs that attending physicians that the students may be working with, clinicians who may have little to no AI guidance or maybe sort of finding their own rule sets and things like that. And so it can become very challenging to try to identify what should everybody hold to. My perception is that a lot of the value comes from the college being able to share well-worded and well-developed policies on AI utilization by students with those clinicians that are training our students in years 3 and 4. So we spend a lot of time communicating out when we have new policies regarding AI utilization. We also have regular meetings with the leadership for each of our clinical regions to ensure that they have a good understanding of what the expectations are in terms of trainees' utilization of AI.
Wow, that's awesome. Now, May, just to follow on Saroj's comments, does your institution have a written AI authorship policy today? And how is that policy enforced during daily ward supervision? If you could just elaborate a little bit, that would be great.
Yeah, I'll speak to a little bit more of the clinical setting where a lot of my role as the Assistant Dean of Graduate Medical Education is interacting with program directors and leadership at graduate medical education training programs or residency programs. And it's an interesting phenomenon because people are in different stages of developing policies as well as enforcement of policies. So I would say there's no uniform guidance currently that every program abides by in terms of how policies around AI are governed. Each institution has their own sort of way of handling this. And what we try to do is to look at the research in terms of what does the research say about how learners should engage with technologies and clinical decision support tools, and try to educate the faculty on this. So I would say that the sort of programs that are probably ahead of the curve in this have developed governance and policies. They probably have a designated person that is responsible for sharing out these policies as well as enforcement. And programs that are just coming to this conversation are grappling with, what do they need to do in their particular clinical setting to ensure patient safety and sort of maximal learning of the resident physicians.
Thank you, May. Shivam, when residents present AI-assisted plans during rounds, how do you ensure their clinical reasoning is visible and defensible beyond the final answer?
I think part of it is just transparency with residents, asking, have you used this tool? I think it's not necessarily a bad thing for them to use that tool and for them to even admit to using it. It's just so it helps inform the conversation and helps us ground what we're doing in evidence. And then also a lot of it goes back to like what you gave the tool when you are asking for advice. Or did you give the full patient history? Did you include certain labs that were notable? And having that sort of decision trace and that context trace, I think, is helpful to make sure that they're using the AI tools appropriately and not just getting it off, like a one really poorly worded prompt that may actually misguide the patient's treatment.
Wow. Gregg, I want to comment on Shivam's answer because there are some really important points that Shivam made there.
Yeah.
And I want to make sure that we're clear on what those are. So one thing Shivam pointed out is that it's okay, or it should be okay, to use AI. And I like the idea that at the most general or basic level, you could say that a policy would be yes, but with transparency. So using AI, but with transparency would be a great starting point. And then I think the other point that Shivam is implying, and Shivam, please correct me if I'm wrong, is that we have to get away from this idea of thinking about AI as necessarily cheating or taking the easy route, because as long as that mindset persists, it's going to really stunt the utilization of AI, but it's also going to direct people away from AI when AI can actually be very helpful. And it may somewhat truncate AI's ability to augment, and that's what we're really talking about, not artificial intelligence, but augmented intelligence. It can really truncate AI's ability to augment what learners and trainers are actually doing. So thank you, Shivam, because I think you really codified something that's been on my mind for a while.
Thanks, Saroj. I totally agree.
I just want to add
out there's not a huge level of consistency of the type of tools they're using and the types of LLMs they may be accessing. So that puts a lot of pressure on the attending who may be overseeing that resident or that trainee.
Yeah. And a lot of the work that we do is to try to give that education about how to source information and which LLMs to use to have more evidence-based clinical guidance. And so even though there's not a set standard among different residency programs, we all really look to the research to really fully understand what makes a difference. And so in the light of what my colleagues here shared around critical thinking and sort of transparency of AI use in the clinical education setting, I just want to point to a article that was research article that was very beautifully put together by colleagues up at UCSF that was published in the New England Journal of Medicine. It's called The Educational Strategies for Clinical Supervision of Artificial Intelligence Use. And to what Shivam spoke to in terms of the importance of critical thinking and prompting, as well as transparency, are standards that I think, regardless of where a program is in developing policy, they can trust that the research has been done to really point toward the importance of critical thinking when it comes to interaction with AI.
Wow, thank you, May. All right, let's go on. Let's look at a real life scenario, that 3 a.m. scenario. The doctor's exhausted, and he's been on shift. I don't know how long you guys work. It's 24 hours considered a long time, 48, I'm not sure. But you're exhausted. You stop questioning the results in the computer screen. You just want to survive the shift. How do you ensure a resident can clearly define or defend the logic of a plan, even when AI assists with the drafting or analysis?
So to be honest here, I think the interesting thing is that most AI tools are so poorly integrated into people's workflows that just that barrier is enough of a guardrail in itself. When it's 3 a.m., you don't want to be figuring out how to prompt an LLM and type in this stuff, pull out my phone, go to UpToDate. In fact, you often see them maybe even using it less a little bit because it takes more work versus once these tools get more and more readily integrated into workflows, I think you're going to see a lot more of that. Oh, I'm just delegating to AI as a crutch and not doing as much clinical thinking of my own.
If you differentiate between what Epic's coming out with in terms of Cosmos versus the use of ChatGPT for health or what Claude is doing, et cetera, where do you see more promise and perhaps organizational liability as well?
I think the biggest promise is with chart integration and specific patient context integration. I think that is where the models are good enough. I think at this point, the models are so well designed enough that if you give them the right information, they will do a good job and honestly probably better than the average physician. The challenge right now is that context engineering. It is getting that patient information and only the relevant patient information and giving that to the model so it can create insights from that information. And I think that's where the most promise really is.
God, thanks, Shivam. Renu, when a reliable signal tells you a trainee understands the underlying reasoning behind the decision and not just the surface output, how do you make that determination, the signal versus the noise on the thinking of the resident or trainee?
Gregg, I work with a unique set of medical student. I work with the preclinical student. And in the realm of really grassroots medical learning, I think the focus really is on getting students to understand how to use the tools and be able to apply them in the future in what they do in terms of clinical integration. We have a pretty unique spot, I believe, because not only do we have the ability to shape a mindset, we also have the ability to contribute towards creating the relationship with AI and AI tools. What we have done, what we strive to do thus far is to just make sure that they're learning right and with the guardrails in place. I'm sorry, I'm not really good at this, so you have to cross me out a lot of times. I'm not a big talker about opinions and thoughts, but we just want our students to be able to develop a great relationship with AI tools so as to be able to have the clinicians later be able to mold them in the direction that they need to be.
Which would also include the use of patients also using this class of tools as well, in the patient care process.
It's really important what Renu's talking about. There was just an article that was released about 2 weeks ago that talked about the fact that Gen Z and Gen Alpha are the generations that are least interested in learning how to utilize AI. And a lot of the article postulates that the reasoning for that is they're worried that AI is going to take away jobs and essentially negate their necessity in the workforce. And I think what Renu is talking about, and Renu really well said, is this idea that we really have to get these younger learners to not only use AI ethically and appropriately, but to find the value in AI, because AI is not going to go away. Anthony Chang, who's the chair of the American Board of AI and Medicine, he says this all the time. He says that AI is not going to replace people, but people who know how to utilize AI appropriately will replace people who don't. And so I think Renu's point, which I wholeheartedly agree with, is we have to teach our students how to use AI so that they are the people that are actually leading the forefront of medicine going forward.
Actually, that is an excellent point. So what is the differentiation between the self-motivated learner of how to utilize AI versus what you actually teach in a more formal clinical setting or during classes?
I lead an AI research group at ATSU. And what we're trying to understand is, what do students think? What are their motivations? How do they step into this world of AI so that they may be able to use AI tools better and with a better relationship and ethically with the guardrails in place as they transition into clinical science? So what we're interested, of course, we started with a baseline evaluation of all our students across all our schools to get an understanding of where they stand. And we found some very interesting information about the challenges and the caution that they face. Now, based on that understanding and that information, we actually launched out a set of workshops for our faculty as well as our students, and both Dr. Misra as well as Dr. Veda participated in those. And what we wanted to do was create a scaffold, create a safe scaffold for our students to be able to grow easily into and branch from there. So what we are doing is the faculty and the research faculty especially and other senior faculty, what we've come together and we've gone through all of the AI tools available right now carefully and exhaustively to be able to pull out the tools that are needed by our students at this time in preclinical sciences. Not the HRs, not any clinical reasoning, detailed reasoning at this time, but just beginnings of how to do spaced learning, how to be able to visualize knowledge, to be able to understand what kind of a learner you are, to be able to synthesize scientific literature, to be able to learn how to work with virtual standardized patients. So that's really where we are, and we're hoping that we will be able to send these students in a year or two over to the doctors here to be able to train further and probably not be as confused as they probably have the folks in hand.
Renu, that was really well put. I think you're a really good speaker. I just want to contrast this maybe with Stanford. How does this compare to the way Stanford's approaching the use of AI, within medical education?
I think I agree with Renu on a lot of points in that it's interesting we've seen this kind of flip. And traditionally, right, you have attendings showing medical students or residents, and assuming they have more knowledge on how to use these tools. In the vast majority of clinical reasoning, you have that assumption. Versus now, a lot of times you have the trainees who are both maybe have a little bit more time on their hands, and because they're just a little bit more leaning into the use of these tools. And they're actually training and upskilling our attending and faculty. So we see that. I think another thing we've decided to focus a little bit more on is how these models work from like a core principle, first principles perspective, because I think giving them an understanding of how the models work in an easy to use, understand way, understands how they fail. It lets them understand how they fail. And when the model does something weird, a lot of times if you have a basic understanding of how the model works and how it was trained, you can say, oh, it failed because of this, and this is what I should try instead. And I think with stochastic models like this, having that first principles understanding is really helpful to using the models effectively.
That does put a lot of pressure on the attending, though, right? To understand the tools, the pros and the cons and the limitations. Well, then again, they're at Stanford. Of course, they're really smart. But that does put a lot of how do you prepare faculty to be able to do that in a meaningful way? Because some people are just more curious than others.
I think that is a really hard challenge that we're still trying to solve. That's part of the reason why my role of Associate Director of AI and MedEd came about, because faculty weren't comfortable. They said, I use these tools a lot, but I don't feel comfortable. I'm not a CS expert. I don't feel strong enough in this topic to teach people with authoritative guidance. And I think a lot of my role is upskilling the attendings so that they can effectively teach all the students, because, the reality is I can't sit there and teach, 400 medical students and, 1,000 plus residents how to use these tools. It has to be the people that interact with them on a daily basis.
Got it. Okay. Hey, Saroj, how do you confirm a resident might understand the underlying pathology and can explain it clearly without relying on AI summaries? How do you make that judgment at 3 a.m? Maybe there's a critical patient situation that's occurring, so you don't have a lot of time. How do you make that assessment?
Well, the first thing is, if I'm up at 3 a.m. at my age, there's a problem. I turn it over to younger doctors like Dr. Vidak and Dr. Lin, who are there. But all kidding aside, I think when you're talking about assessing clinical reasoning, nothing has really changed in that approach, because the AI can generate answers for you, and the AI can even generate a reason for why the answer is right. But it can only do that if you're providing the prompting. And so if I need to assess clinical reasoning, I do the same thing that I would do before AI was even an opportunity, which is I would ask more questions, right? And so one of the things that humans have the ability to do is essentially generate as many questions as needed, on the fly in real time to assess clinical reasoning. So if a resident, let's say, for example, a resident told me they wanted to use amoxicillin for a patient who appeared to have pharyngitis in the hospital, I might ask them, tell me a little bit about why the amoxicillin is a good choice. And they may have gotten those answers from AI. And if they did, hopefully that yes with transparency that Shivam was talking about would be really useful. But I might ask follow-up questions. I'd say, well, tell me a little bit about why, for example, a cephalosporin wouldn't be the best choice, or why did you choose amoxicillin versus injectable penicillin? And so I can pose questions. But one of the things that comes along with that, as you might imagine, is that the person asking the questions then has to have a fairly strong clinical background and a broad base to be, whatever it is, whether it's clinical or even at the undergraduate level within those first 2 years with basic sciences, you have to have people who know their field well so that they can generate the right questions to ask. And eventually, I think that it does not take that much to actually get a sense of whether your learner has received information only from the AI system and is just spitting back that and knows nothing outside of that. But that's not always the worst thing, because in our program, for example, I always tell them that the 3 most powerful words for learners are, I don't know. Because once you acknowledge, I don't know, that's when we can start to learn and fill in the gaps and understand. But if you're just spitting out answers, so I actually try to question my learners until they get to a point where they say, I don't know, because that's really where my teaching starts.
Yeah. May, what are your thoughts on this, Todd? Because you just cited some articles. And do we need to be changing our protocols or our tests around so this is actually a part of the whole interaction between the faculty and the trainee?
Yeah. Well, it's such a great question, Gregg. I think the really tricky part about AI, it is something that is unprecedented in terms of for us as a society and us as teachers, for us as medical educators. And so with something that is really innovative and unprecedented requires a paradigm shift in the way that we think about how learners learn and how we teach. And I think Dr. Misra really spoke to something that I really believe is key in this process, and that is a big dose of humility. Listen, a lot of research is being done, a lot of conversations are being had, and all these things are good, but there are also a lot of unknowns in terms of what this ultimately means for the way that we teach learners, the way that the learners deliver care to patients. And so I think the best way to mitigate the risk of, what direction do things go, how do we best instill competencies in our learners, is really to say there's a lot that we don't know and let's learn together. And so that's where you're seeing a lot of the sort of interactions, maybe like maybe a good way of saying this is in the way that most of us learned, it's like there was an understanding that the attending physician knew more than the resident physician. And I would say for the most part, the experience speaks volumes in terms of how to care for patients. But now we have this really cool tool that can give us information that none of our brains could have absorbed at the speed that this large language model could have absorbed. It can reach thousands of research articles within a short period of time. And so how do we as collectively, as both attendings, as well as resident learners, as well as medical students, work together to utilize a larger breadth of information to deliver better care and increase access for patients? So I think it requires a lot of humility and a paradigm shift about how we learn and how we teach. And that's how we move forward in this conversation.
Excellent point. Shiv, let me bring it back to you. On a busy shift, it is all about hidden incentives. How do you reward a resident for being thorough when the hospital might be measuring how fast they work? At least a lot of docs I've interviewed around the country, it's all about these RVUs and how many patients you can see in a given unit of time. So how do you balance this out, right? Because it affects the bottom line of the hospital.
I think that tension has realistically existed with education and operations for generations. I think a hospital always wants us to go faster and to crank people, see more patients more quickly, maybe spend a little bit less time on each patient so you can see a higher volume, versus the mission of education has always been kind of a little bit antithetical to that, right? It's always been we want to spend more time and talk about this patient more thoroughly, and I think the complexity of patients at academic medical centers often demands that as well. And I think that this is a tension that's not necessarily something that's new, and it's something that we are just navigating through a different lens now, and with an additional team member, which is AI, also along with us.
I'm just really interested to dive a little bit more deeply into this, because I think it's really important as new technologies emerge that we really learn from lessons learned in the past. And we have great opportunity to be able to do this in the conversation of AI. Now, listen, there are realities of numbers that we need to think about in terms of, the bottom line. And we all understand that reality is one that we need to navigate. But when it comes to healthcare, really, where should our incentives be, right? Is it really incentives for profit? Is it incentives for access for patients? Is it incentives for quality of care? Now, if I was the person making decisions about how quickly a doctor should see a patient, and I was focused on profits, then yes, I am focused on my RVUs and productivity. But if all of a sudden I am the patient that is battling a very difficult diagnosis, and how do I want the people who are taking care of me to learn, I may have a different perspective about how to approach this. And I think we have real opportunity at this time in history to speak up to things that perhaps we didn't know to speak up on as much before. Should we be compromising time with patients because now we have a cool technology that allows us to see patients faster? Or should we give that time into improving the quality of care? We know that we can get by with X amount of productivity, but I think it's really important for us to not let a very cool sort of tool that can allow us to do things faster to mean that we rush our patient care more and more. I think that would be the wrong move. I guess it is. I would even be as bold as to say that when you think of it from this perspective, wherever seat you are sitting in, if you were the patient, right? Because that's how we as clinicians always look at things. If we were the patient, if our mother was the patient, what type of policy decisions, what type of incentives do we want our clinicians to follow so that they could give us the best quality care?
From a patient perspective, is this Dr. Google 2.0, in terms of the more informed patient, or is it more of a hindrance for the clinician in being able to encourage the patient to take a more participatory role?
I mean, I don't know. And there's a lot there. That is, I think, potentially some of the challenge that we see is that as we start to leverage AIs, so too does our patient population, right? And so the argument, though, is that as we've already talked about, the AI can augment what we know. And to be very honest, I think that's how AI should be looked at, as something that is augmenting the effort that we put in. To use May's commentary earlier, which I 100% agree with, I believe that where AI can help is in reducing the burden of overload of low-level things. For example, documenting an encounter in the chart via dictation or scribing. That's a great place for AI. But I would not feel comfortable at this stage with having an AI make a decision based on predictive algorithms and things like that about what's likely happening and then just institute a medical plan. Because there's a loss of nuance there that is very much humanistic, right? So I think the challenge with letting patients also kind of, and they will utilize AI, is that there's also that same kind of loss of nuance, right? They're allowing the AI to sort of tell them or feed to them the information. But unlike a physician or a trained healthcare provider, they don't have a wealth of background clinical reasoning to sort through what the AI is telling them that may be of value, that may not be of value, and that may even be dangerous. And we've already heard in the literature about how AIs can hallucinate, how many AIs can provide answers that tend to be somewhat biased, especially because AIs are contextual in the information they utilize to collate or generate their answers. So patients don't have the ability, because they don't have the background, to be able to say, yeah, this information is solid and this information is not solid and this information is actually dangerous. And I think and mind you, we have the same problem with Google. We're just going to have a more powerful and arguably more dysfunctional version of Dr. Google with AI.
All right, here, last area now. Saroj, I'm going to give you an opportunity. I want you to turn to Shivam, May, and Renu. I want you to ask them a compelling question about the hidden shifts in trust is creating a risk for leadership. So, Saroj, talk to them in medical speak that would be a compelling issue that you guys would be thinking about if you were at a bar in downtown Kansas City.
Well, listen, if we do end up at a bar in Kansas City, I will offer to buy the first round because I'm asking you the question. But, I was thinking a lot about this as we were talking, and I think all three of you have such interesting perspectives. So I want to ask you, what do you think is one high stakes task in your domain, be it clinical, be it academic, that you would deliberately ban AI for learners, at least for a phase of the training? And that's because it could risk eroding competence. And also, if you think about it, what evidence would make you reverse that ban? So what would make you say, no, maybe AI is okay? So I want to start with Renu, because I want to go in the order of our learners, right? Going from the basic sciences. Mm-hmm. So Renu, is there a task that you feel like at this stage, AI should not be used or should not be used in a section of training for the students that you work with?
Well, I think we have a joint interest in creating a great medical student and creating a good physician. We recognize the challenges of our medical student at large. We recognize that there is just so much of cognitive overload at this stage. Students are finding a way to figure it out, and they're doing it by a lot of times by quick fixes. We have a hyper summarization of data, and physicians that are already in practice, are in residency, who've not grown up in that hyper summarization may be fine. But medical students, the education of students now, as folks that are not reading books or who may just not be able to because there's so much data. So I think the biggest caution or cautionary tale would be to keep the focus on critical inquiry, on keeping the focus on thinking and feeling and emoting, and keeping what really made us physicians alive, to be able to restrict AI tools to something we use, like computers. I had a physician from Kentucky. I was listening to him talk on one of the AAMC podcasts, and he said something that just stopped me in my tracks. He said, AI needs to be everywhere around us in everything we do. We need to make it invisible like electricity. And for me, that really changed how I approach, and my team and we in basic sciences approach education, because we want to create a cognitive exoskeleton created by AI tools. But we want to stand beside our student and encourage synthesis of information, encourage the thinking, encourage the struggle, the intellectual productive struggle that gets people to the determined level to decide, hey, this works, this may not be right, versus, an automation bias everywhere around us.
Interesting.
So again, grassroots, but I think critical to what makes a great physician.
Renu, that's a really good point. All right, May, what do you think? What should we ban AI from, either in total or even just for a phase of training? Is there something that comes to mind for you?
Okay, I'm gonna pull one, and I don't have a great articulation of it, but I think I'll be able to describe the spirit behind this. Is I would institute a ban on banning AI.
I love it. That's fantastic.
The
Explain
reason
that a
being
little bit.
that AI really has the potential to upskill the way that we take care of patients, to increase our skill set and at a faster pace. There are opportunities in being able to learn new paradigms of how we learn and how we care for patients through adaptive learning, right? And if we don't make those tools available and available for exploration, available even for failure in low stakes situations, then our learners miss the opportunity on how to understand what the limitations are and what the risks are. And so I think in low stakes environments, not when the patient is critically ill, but in low stakes environments, we should allow our learners to play a little bit with these tools to understand how to use these tools with proper guardrails. Because then when they get to the high stakes environment, when they are caring for that patient in the ICU, making critical decisions about their vent settings or whatnot, then they know that, hey, this is where the tool is limited and I need to stop using that. And I need to really listen to the family. I need to do the human part of this, right? I know based on experience that the vent settings for my other patient, worked this way, even though it was really outside of the text, of what I would have expect the textbook to say. They need to let that kick in high stakes situations. And so I would institute a ban on banning AI use.
I love that. I think that's a really thoughtful thing you've just said. So, Shivam, how about you round us out here? Give us your perspective on what, if anything, would you ban learners or trainees from using AI for, or even for a phase of their learning or training?
Yeah, I like to caveat what I'm saying with, I totally agree with May. But I will say that there is the current state of AI where we do have physicians in the loop verifying. I think that I would currently honestly ban AI for the assessment and plan generation for internal medicine hospital SNFs. And the reason for that is that there's so much cognitive processing and your clinical reasoning you're really doing when you're writing that assessment plan. I think it's maybe slightly different from the outpatient setting where you can discuss those things verbally. You're getting new information that's trickling in over time, over the course of the day. And I think that if you were to automate that entirely, if you go to a place that, let's say they did ban AI, or for whatever reason they don't have those that tool in place, it's going to be very hard for you to do that organically. And I think that trainees need to be able to do that organically without having the AI assisting them. They can have the AI double check what they're doing and to verify that what they're doing is guideline oriented and things like that. But that entire process of writing down what the plan should be, I think is something that's intrinsic to what at least a physician does in internal medicine. And it would be if you automated that, then I think you're almost in a way automating a lot of what we do in general. And it would be very hard for you to verify AI outputs.
If I may quickly,
please, Renu.
Apologies for interrupting, but if I may piggyback on what Shivam said is feedback. And we need to be able to separate AI from feedback.
That's interesting. Gregg, back to you.
This has been awesome. I think we're out of time, but this was a great dialogue today. So I want to thank Shivam, Renu, May, and Saroj. Key takeaway is simple. If we don't teach doctors about the challenges of AI, we aren't training them to lead, and we're just training them to follow a screen. So I think today was a very timely discussion. I'd like to thank you for joining us on Beyond the Blueprint. My name is Gregg Malkary, and I look forward to seeing you next time.
Thanks, Gregg.
Thanks for having us.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.